Am I audible?
Yes, ma'am.
Hey, good afternoon, all.
Good afternoon.
So, first of all, I would like to welcome you all of for the next session and a very warm welcome for you, Kamalaka sir. Thank you to be with us. So,
Thank you, ma'am.
I'm hand over to Anusha ma'am to introduce our faculty. Thank you.
Good morning, everyone. Uh, this is Anusha. Today, I'm your facilitator. Today our speaker, Mr. Dr. Kamalakar Garu, is a dedicated physician with a unique academic and professional journey. Originally a science student and passionate in social work, he qualified the national eligibility test for lectureship before pursuing a career in medicine. And later he learned his MBBS degree, followed by multiple certificates in palliative medicine, reflecting his deep commitment to patient-centered and compassionate care. Currently, Mr. Dr. Kamalakar is also pursuing a one-year fellowship in geriatric medicine for expanding his expertise in caring for the elderly. And he has vast experience in hospice and palliative care. He brings both clinical excellence and humanistic insights to his work. He currently serves as a palliative care physician at Sparsh Hospice, where he supports individuals and families through some of most vulnerable stages of life. So today our topic is gastrointestinal symptoms, nausea and vomiting. I'm hand out to Dr. Kamalakar Garu. Thank you. Dear participant, if you have any doubts, please put it in chat box.
See me. Where is it? The folder. We open editing.
We'll start soon. We have some technical errors. Select a mic on. So, dear students, what are all the digestive palliative care? Can anyone say?
Suffice. निशा नहीं है
Mute Jason. I cannot see them, but I'll. Yeah. See, yeah. Right. Sorry for that delay. This is Dr. Kamalakar. Good morning, all of you. Hope I'm audible. Am I audible?
Yes, sir.
You know, it is. Yeah.
Yes.
Yeah. Fine. Yes. All right. Sorry for that delay. This is Dr. Kamalakar. Am I audible? Hope I'm audible.
Yes, sir.
Sister Anusha, am I audible? Is it okay with them?
Yes, sir. You are audible.
Can someone acknowledge that?
So audible.
We can hear you clearly, sir.
Right.
Yes, sir.
Great, great. Okay, then we're good to go. Right. So now, as you see this in this session, actually the ECO Foundation course today, we are going to learn about gastrointestinal symptoms management in palliative care. So far, I think you have already undergone introduction to palliative care and pain management, I think, and also communication, I see. Yeah. So in this topic, we are, going to deal with few gastrointestinal symptoms management in palliative care. Among that, usually we see nausea and vomiting. And today's topic is nausea, vomiting, and constipation. Okay. Yeah. In case you have any questions, you don't understand anything, or you don't understand a word or a sentence or anything you don't understand, please raise your hand. Sister Anusha is there to help you, and then you can unmute and directly talk to me one after one. Okay. We have enough time, and I appreciate all of you that you chose palliative care course. That itself a great thing. And then I want you to learn everything in a very organized, scheduled manner to help the patients in future. Right. We'll start with a case scenario. You can see a case scenario here. Imagine that you are a palliative care nurse now. Okay, now palliative care usually can be provided in a hospice center like this or in any hospital or home care also possible. Here we have home care. Usually we have about 6 to 8 vans and then our people, our social workers, our nurses and doctors, they go to the patient house and see them in their house. Yes, they mentioned that it is audible. Yeah, right. Okay, look at this case scenario. So now you're the home care nurse on a call. A family is calling you saying that sister, he hasn't passed motion in 4 days. He says he feels full and today he vomited after eating. What do we do? This is the call, you are receiving from a family. Imagine now you're receiving this call, you're there at this end. So, what are the first few things that come to your mind as a nurse in this situation? When you receive this type of a call, what are those things immediately, go through your mind when someone says such things? I want one or two responses. In case someone wants to respond, you can raise your hand. Sister Anusha is going to help you, and then you unmute yourself, and you can ask, you can speak out. Yeah. In case someone calls you and says these things, what is that? What are those few things immediately goes through your mind? Excellent. I see that there are two participants raised hands. One of you can unmute and mention that so that everyone can hear. Huh?
Hello, sir. So in this case, probably we would assess the patient first, like few details we will collect from the patient, like what kind of a food they had few days before and what is their water intake, and is there they have any other disorders with the abdomen or the gastrointestinal system. And after initial assessment, then we will inform to the consultant, and probably if they advise the medication, then that would be administered to the patients.
Excellent, excellent. May I know your name?
Shiv Kumar, sir.
Shiv Kumar. It's really excellent. Immediately, when someone calls Shiv Kumar, he would think this way. Excellent. He was thinking about what patient must be, eating earlier and what disorder they were having. All those are very, very important questions. Okay. Anyone else wants to, share your thoughts?
Including all these things, we have to check the medication, what medication patient is taking, maybe the
Hmm.
side effect of the medication. So we have to check, or accordingly we have to give the doses or lower the dose of that medication, like morphine, if the
Excellent.
patient is taking morphine. So this is the main
True.
side effect.
True. Very excellent. May I know your name, please?
Sir, Jyoti Son.
Jyoti, Jyoti. Excellent. Both of you really excellent. So that is what we are going to learn today. Okay, in case someone calls you or someone you see at one point in your practice tomorrow, how are we going to handle that symptom? Your both are really excellent. Even the medication can also cause, nausea, vomiting. We need to check their drug chart, what medicine they are taking. Is there any medicine precipitating vomiting? Okay, excellent. Yeah. Now let us continue. So before going to go to this topic, just a brief, about GI system. So you all know about GI system, and you can see in this image and all the parts of the GI system. And then what is the major potential function of our GI system? Usually there are three potential functions of our GI system. So in case if one can answer, please raise your hand and then accordingly we can take one after one. Huh? The potential functions of or major functions of gastrointestinal system or digestive system? One or two responses if possible. No? That's
Sir,
okay.
please repeat your question once.
Sorry, ma. Sorry. You want me to repeat the question?
Yes, yes, sir, please.
Okay. What I was asking, what is the major function of gastrointestinal system? Major function. What it does. What
Digestion and
is
Sir,
elimination.
someone mentioned elimination? Excellent.
Digestion and elimination, sir.
Excellent. Excellent. And someone else is on call. Someone is also trying to say something.
Breaking foods in small pieces.
Sorry, ma. Can you repeat?
Breaking food in small pieces, small molecules.
That's, yeah, basically digestion. Right. Good.
sir,
Look at this.
absorption of nutrients.
Very good. Very. You're all right actually. It is usually basic function is digestion, and then whatever food is digested from that, the nutrients will get absorbed into our blood, and then elimination of those.
Removing wastage.
Yes. Very good. Now look at this. Today's topic we are going to discuss about nausea and vomiting. Anything in this system, any disorder or disease, not only in digestive system but also other systems, we are going to learn that also. That is going to cause nausea and vomiting. So, without wasting time, look at this table here. Look at what is nausea. Nausea is kind of a feeling that you want to vomit. It is kind of a sensation and it is subjective also. What is subjective? Subjective in the sense, for me, it is different. For you, it is totally different. It is an individual experience. For someone looking at very unauspicious thing, or maybe sometimes you also, looking at blood, sometimes you feel like vomiting and nauseating. For others, maybe not. For others, maybe looking at some typical food. For me, maybe a Chinese food is going to nauseate me. For you, maybe you're going to like it. So it is subjective. So it is kind of a sensation. And vomiting is a physical action. You want to forcefully, expulse total stomach contents. That is an action. There is a difference between nausea and vomiting. It is typical subjective sensation, whereas vomiting is forceful action, physical action. So look at nausea and vomiting. Nausea can occur alone without vomiting. Sometimes you only are nauseating, but there is no vomiting. At the same time, vomiting can also occur without nausea. You are not nauseating, but you immediately you want to vomit. There is no nausea, but there is vomiting, and both can occur together also. You nauseate and then immediately vomiting. We'll come to know what is the mechanism behind nausea and vomiting also. Okay, and maybe managed. Nausea can be managed with some rest or deep breathing. All those things. And coming to vomiting, you cannot control it. It is harder to control. Once vomiting, the typical action starts, you can't control that action, right? Look at what patient says about nausea. Nausea is like, I feel like throwing up. And then coming to vomiting, they already threw up. Look at this typical busy picture, but I'll try to simplify as much as possible. Look at those, color codes, the green and the red centers there. Coming to the green one, it is called chemoreceptor trigger zone, and the other one called vomiting center, right? For example, just now I mentioned, is there any unpleasant stimuli, any unpleasant smell or sight or something, or emotional shock also? That is actually taken by the cortical area, and from there it is going to give the inputs to the either vomiting center or chemoreceptor trigger zone. We are going to learn about this little more, but this is just to give you a typical visual analysis to think about it. Okay. Yeah. So basically, nausea and vomiting, when we discuss, these two centers play major role. And what happens to those centers, why they are triggered, and in which center when it is triggered, we are going to learn those things, right? Yeah. Look at this. This thing is, can you know that? Yeah. Right. Yeah. Yeah. Yeah, look at that. The types actually. Huh? There is something called sensory related nausea. When you see something or you taste something or any unpleasant sound or experience, that is called sensory related. And then what happens? You took that sensory input and it is going to the cerebral cortex. And from there, it is going to the vomiting center. In turn, the vomiting center is, asking your gut. Look at this, from the vomiting center to the stomach. There is a signal, and then what happens? It is asking you to vomit, empty the stomach. Why this is happening? Why this happens? When you look at something and you see some unpleasant smell. Sometimes our patients, someone is cooking in the kitchen, some fumes from the kitchen also disturb them. They cannot take it. Someone is cooking somewhere in the kitchen, in the drawing room, they feel like nauseating and vomiting. And then the same person used to like it very much earlier, but now unable to control it. Why? It is subjective feeling, but why it is happening? That is kind of a protective mechanism of your body. When something abnormal you sense, and the body senses, and it is giving the input to the cerebral cortex, and then it is asking you to vomit. That means the body is thinking that there may be toxins, there is something harming my body, so that I want to vomit and protect my body. That's the reason this happens. And then coming to disease related nausea and vomiting also. For example, some infections. You must have known about buccal mucosa cancers, right? The oral cancers. Looking at the such, I don't know where you're working. If you have experience, you must have seen such patients with typical infiltrating huge buccal wounds with maggots and all, full of foul smell and slough oozing out. So much of infection and dead skin there, so much of foul smell there, that itself causes nausea. Cancer, an organ failure also, sometimes liver failure or renal failure can also more creatinine loading in the blood, or more urea, more liver enzymes in the blood can also cause nausea and vomiting. Someone mentioned in the session in the earlier examples like opioid medicines, drugs, just like vomiting, uh, what opioids for now, the morphine, tramadol, these are all the opioid you must have learnt in the other class. So even these opioids can also trigger nausea and vomiting. Sometimes raised intracranial pressure also. In case there is a tumor in the brain, there is mass in the brain, these things can also trigger vomiting center, chemoreceptor trigger zone, and then in turn, nausea and vomiting happens. Yeah. The examples of disease-related nausea you see there, uremia, in renal failure, gastric liver failure, and brain tumors, and chemotherapy. Yes, chemotherapy can also cause nausea, vomiting. This is the most common symptom when a patient is undergoing chemotherapy. The chemotherapy drugs in turn cause nausea and vomiting. Most of the patients, they undergo this problem. And pregnancy related nausea and vomiting. Why? Because in pregnancy there is hormonal typical fluctuation, just like human chorionic gonadotropic hormone we call estrogen. All these hormones actually they fluctuate. They are high in numbers sometimes. Usually in the first trimester, first 3 months of pregnancy, usually they feel like typical nausea and vomiting. They cannot like any food, and sight of the food, and taste and smell of the food also they usually hesitate to take. So this is because these hormones usually they influence on chemoreceptor trigger zone. CTZ, and in turn that is going to improve gut motility, and hypermotility can cause nausea and vomiting. Look at this sensory related nausea. Usually the vomiting center is involved through cerebral cortex. Disease related nausea and vomiting, typically chemoreceptor trigger zone is involved, and even pregnancy related nausea, typically the chemoreceptor trigger zone is involved. Usually people also have motion sickness. Someone is, on wheels, they usually have motion sickness. Here, we are going to discuss the second one, not the sensory related or pregnancy related. We are going to discuss about disease related nausea and vomiting, typically in palliative care. Usually you see in palliative care, typical terminally ill cancer patients, right? Bedbound, geriatric patients, liver failure, and, renal failure patients. Usually you see them. So we are going to typically discuss about that category in this session. Yeah. I am sure you all know about this, the typical GI cancer. Whatever the GI part and system, there is a possibility of cancer. Esophageal cancer, stomach cancer, intestines, colon, rectum, anal, liver, pancreatic cancers. Right. And the prevalence of this nausea and vomiting in palliative care, usually we see, 50 to 60% palliative care patient, they feel nausea, vomiting. Today, when I go for rounds in my ward, typically we have 8 patients in 8 cubicles in personal spaces. In 8 out of 8 patients, 6 patients, they, complain about either nausea or vomiting. For many reasons, we are going to discuss. Any questions till now? Right. 1 minute, sorry, there's a technical problem here. Okay. Is it okay? Is it okay? Right. Yeah. So when you don't treat this, what happens? It leads to debility. Then patient usually, you don't eat, you want to vomit all the times, and nausea. There is nutritional deficits. There is no proper input and no digestion, no absorption, and then you will be dehydrated when there is no proper sodium, and other electrolytes are not absorbed into your bloodstream, and electrolyte imbalance happen. And then aspirational pneumonia can also happen when you don't treat. You know what is aspiration pneumonia? I'm sure you must have known about it. Just to mention, when someone is vomiting and it is not controlled and they're totally cachectic, like they're totally debilitated, they have no strength also to control, or, to reach out anything, there's a possibility that it might enter into lungs also, right? Any question till now? In case you have any question until this slide, you can raise your hand. Otherwise, we can, continue forward. All right. Yeah. Now look at this case vignette. Mr. A, 60 years, with pancreatic cancer, complains of nausea and occasional vomiting for 2 days. We'll go through this case scenario and understand what your assessment should include when you see such patient. For example, you are my colleague. We both are working in one center. So now I have to go for grand rounds this morning. You are the nursing in charge there in that ward. So in my ward, typically one nurse and one nursing aide and one ward assistant. Ward assistant in the sense Aya, usually we call Aya. So all three together, they take care of about 8 patients. So when I go for rounds, maybe I'm going to take care of 30 patients today. Is it possible for me to spend about 30-40 minutes with each patient? Practically not possible. Now, when I have a very competent nurse like you, now a patient is telling these things in the ward today to you. So, what do? You have to thoroughly assess this patient and present it to me. Then when I come for the rounds, when you explain these things to me, and it will narrow down the assessment, and then we can precisely care this patient and address their symptoms and provide medication, right? That's the reason I'm going to focus more on nursing side of an assessment. Right. Yeah. So what your assessment should include. Okay. So we are going to see that. Look at this busy assessment table for nausea and vomiting. Don't worry, we'll at a time pay attention on one area. Okay. Look at this history. First thing is about how excellent you're taking the history. Okay. In the history, what to look for? What are you going to look at in the history? Yeah. So when someone like this patient mentioned, complaints of nausea and occasional vomiting for 2 days, you're going to assess this patient. And in your history, what are you asking that patient? When did it start? How often you're vomiting? What comes out of vomiting? Like what color it is? Is it green, yellowish, black, red? You know, all those things are very much important. And triggers when this is happening. Is it because of typical smell or when you sleep on a supine position or when we are giving a tablet of medicine then you're vomiting or with food intake, or headache is a reason. So you are going to, thoroughly assess this patient. What is triggering this patient to, get vomiting and associated symptoms. You're vomiting, fine. With that vomiting, are there any other associated symptom? Is there any headache before or after vomiting? Constipation we need to rule out and pain also. So we need to, don't think this case is only the best example. This is only to, bring your attention into assessment. Okay. Don't think about exactly this person. Think about your assessment. And why do we need to assess this patient? Because when you take this history properly, it helps the patient symptoms narrow down and the cause also, where it is happening. It is gastric symptom or central nervous, system. Is there any headache or drug related or because of any gastrointestinal obstruction? You're going to precisely understand why this is happening. Yeah. Now, associated symptoms like dehydration, as we discussed, dry mouth and low urine, electrolyte, imbalance and confusion, cramps. This is obstructing my way. Right. Now, and then also you're asking the patient history. Now you're examining the patient. What do you examine this patient when a patient complains like that? Pancreatic cancer and vomiting. Abdominal examination. What is that abdominal examination include? You look at the abdomen. The abdomen is, total, distension is there. Is there any visible movements, peristalsis you could see? Distension is in sometimes maybe because of mass or ascites also, some fluid accumulation in the peritoneal cavity also. You see why the distension. You at least observe the distension and then you think about why the distension is there. You'll go back to the patient uh, diagnosis. What is this diagnosis here in this patient? Is pancreatic tumor. Maybe because of the tumor growth, we don't know. Maybe because of some obstruction, we don't know. So that you assess thoroughly, end of the day, you'll understand why this is happening. And you feel that abdomen. When you touch the abdomen, give some pressure and immediately remove your finger. Maybe patient is complaining of typical pain, maybe tenderness, and you also, by using this stethoscope, you hear the vowel sounds. Sounds are present or absent. In case sounds are present, what kind of a sound is it? High pitched sound, low? All those will give you a picture. Yeah. And the rectal examination, the most important part. I usually every day I mention this to my nurses in the practice also. Rectal examination. What do we do? Is there any hard stool impacted in the rectum? Any mass, fissures, loss of rectal tone? Imagine a patient is totally bedbound, cachectic, their muscle is totally wasted, they have no strength to push the stool out also. And then there's no rectal tone is lost, and then they cannot push motion. Motion is totally there only, total, water reabsorption is happening and it'll become dry and, hard stool impacted there. That can also cause, nausea and vomiting end of the day. Yeah. Often, this rectal examination is missed because impaction can be silent but can cause of can be a cause of vomiting. Every day we usually go through this. Even last week when a patient was, kept on complaining about nausea and vomiting and lower abdomen pain, every one of us giving medicine, nurses are, doing their, examination, but we missed the, rectal examination sometime. But the patient is unable to tell you that whether she passed stool or not. But in the diaper, you find some stool. They may be thinking that she is passing stool. No, maybe not. Maybe totally void. Totally, it is not void. So sometimes we have to check rectal examination properly, and then investigations. In some, liver failure or renal failure, all the, serum calcium levels or creatine levels may be building up. You may have to check that. Yeah. Hypercalcemia, the more, calcium levels in the blood can also trigger nausea and vomiting, and liver metastasis can also lead to nausea, vomiting. So all those things, right? To give the gist of this assessment, whatever, the assessment just now we mentioned, the gist of the assessment is about 5-step bedside rule. What is it actually? One thing is to ask the patient timing, volume, associated symptoms. And the second one is to look at the abdomen shape, scars, and peristalsis. Listen bowel sounds and feel the abdomen tenderness, any mass, ascites, something like that. And check the PR. PR means per rectal examination. Is there any stool impaction or something like that? Okay. Yeah. Now, what are the common causes in palliative care, especially in palliative care? Our internet connection is unstable, they say. Right. Yeah, look at the common causes here. Medication, opioids like, morphine and, tramadol can also cause, and chemotherapy. The mainline chemotherapy drugs can also cause nausea, vomiting. NSAIDs. What are those NSAIDs? Usually, the ketorolac, diclofenac, all those in that line. Antibiotics can also cause nausea and vomiting when you don't know when to stop it. And gastric causes, gastritis or ulceration because of the disease. Gastric stasis. What is stasis? Whatever the food you take, it is staying longer hours there, only more acid accumulation and, more regurgitation into the throat and you want to vomit. Carcinoma of stomach, gastroduodenal obstruction can also cause. These are the most common causes we see in palliative care. And then biochemical causes, just now we mentioned all other organ failures also. And also other causes like any raised intracranial pressure. We discussed this already. And then use of antiemetics. What is antiemetic? Emesis is, vomiting in other way. Antiemetic is the medicine which is controlling that. In palliative care, I'm not going to give, many medicine. Usually in palliative care, what are the most common medicine we use and nursing point of view of using that medicine also. Okay. Coming to this most common medicine we use in palliative care is called metoclopramide. Anyone what is metoclopramide? You can raise your hand and answer, no problem. Metoclopramide. Have you ever used metoclopramide? I'm sure all of you must have, come
Antiemetic,
across
sir.
metoclopramide. Excellent. What is metoclopramide? What is the common name usually we come across?
Perinom, sir. Next, the name.
Excellent. Very. Perinam is usually the brand name, and the generic name of that medicine is
Metac.
metoclopramide. So I always, request you all always use the generic name of the medicine than the, brand name of the medicine. Okay. When you mention the generic name, you can get any brand, no problem. Need not to promote only Perinam. So it is metoclopramide. Okay. And the route, what are the routes we can give this metoclopramide? Orally can be given, subcutaneously, and IV route also can be given. Have you guys used subcutaneous route of metoclopramide ever?
No, sir. Never.
Yeah. So now you are learning that also. In palliative care, very much preferred route is subcutaneous route. Okay. I think you have a lecture on that also. I'm not going to delve into more, but why we use subcutaneous route? Imagine a patient is suffering from, 6 months or 1 year and they have no muscle at all. And then so much of chemotherapy and many, many medicines and IV lines put on, and then unable to find an IV line. When you are a nurse, you are excellent, you're a professional, but you could find an IV line and you keep you find the blood vessel and keep the line at least 24 days. But what happened by evening, that is failed. Another nurse in the another shift, again they are excellent, they are professional, they want to keep another cannula. We can do anything, no, but is it justifying the patient? That's the reason subcutaneous route is painless most of the time. Accessibility is more, you can access. There's much area for your vein, maybe one or two areas. Once they collapse, you cannot use the other area, swelling. The injection you are going to give through that IV line, the benefit of that injection already, overtaken by the burden of by giving that IV route. So, sub-Q is the best route usually if it is possible in, palliative setup. So, metoclopramide, the same dose you can give subcutaneous route also. Okay. And when you are a home care patient, you're looking at a home care patient in a village setup, you're going there, no one is available. You can teach them subcutaneous way of giving this medicine. So why are we mentioning these things? You should know which medicine can be given which route. Then you can have your own judgment in the ground level. Okay. Now, when to use this medicine? Nausea due to gastric stasis. Which medicine when to use we need to know. Nausea due to gastric stasis, and also opioid use and bloating. I would say the best thing is due to stasis. Why? The mechanism of action I'm not going, but I'm trying to mention few things. Metoclopramide is a kind of a drug which will cause, forward movements. Like, when you give this injection, it will cause gut motility forward. When something is staying in the gut, when a movement is going forward, it will be going forward. Whatever the content in the stomach will move forward, and then patient will not feel heavy in the stomach, right? And when you're giving this injection, watch for loose stools. Why? Because I mentioned it is a prokinetic. It is causing a forward movement. Okay, when it is causing forward movement, there is a motility in the gut and intestine. And then what happens because of the motility? Maybe patient can develop loose stools also. So when you are giving this injection, look at this effect also. Not a maybe side effect you would say. Huh? When you don't know about this thing, what would you do when a patient comes to you and sister, I have loose stools today 10 times, then immediately you will give them those things called imodium or loperamide or sporelac or something like that. We will start. We actually haven't paid attention on the cause, but we already started dumping another medicine on this patient. So when you know this, you will understand. And restlessness also, because this medicine is also going to act on chemoreceptor trigger zone. That's the reason in turn it can also cause restlessness and involuntary movements. Especially you look at old patients like over 50, 60, 70-year old, they're prone to develop typical muscle tone fluctuations, either loss of tone or increased tone. They usually have this movement, shaky movements, tremors. Usually in Parkinson's disease, you will see such symptoms, right? Extrapyramidal symptoms, usually we call. When we give metoclopramide in a long run, this can also precipitate those symptoms. When you're giving this to such patients, you should be giving very cautiously. For example, you cannot give this to a patient with typical, Parkinsonism symptoms. So cautiously we can give, okay? But you should mind about giving this medicine to those patients. Coming to nursing notes, what do you need to pay attention is give this medicine before meals. Why? What I mentioned, this is a prokinetic drug. When you give this medicine, it will cause forward movement. You took food and then you gave this medicine. There is heavy food in the stomach and then it is going to cause movement. Then you'll have pain. There is physics in it again. Now, why when are we giving this medicine? Then give before. Okay, is there any anything already in the stomach, gas, acid stasis, already food in the stomach, some amount, and then you give this that is emptied, and then patient feels like eating and no vomiting. no heaviness. And do not use if patient has bowel obstruction. When there is bowel obstruction, when you give this medicine, it is like a forward movement. When it is moving forward, imagine this is the can they see me? Possible? Okay. That's okay. Anyway, we are going to have another session on bowel obstruction. I'll explain in detail there. Yeah. Now, coming to the other medicine, usually we use ondansetron. And this is also, you all know about this. I am using all the generic names. Usually, the popular brand name, Jofa, 4 milligrams and 8 milligrams, tablets and injections you would find. And the route, Jofer can also give oral, IV, and sub-Q also. It is not mentioned here. It can also be given subcutaneous route. Actually, the same one, same. Unmute. All right. Yeah. So when you're giving haloperidol or Serenase, we need to watch for sleepiness and tremors. As just now someone mentioned, it can have sedative actions also. So when you're giving this, usually we also give this, there is one more common palliative care symptom called delirium. So you'll learn about it in the other session. Then also this is the drug of choice. So we can also use haloperidol in lower dosages and vomiting and nausea also. And what do you look for? It is not working. Yeah. What do you look for when you're giving this? Useful at night. Because why it is useful at night? Because it is inducing sleep. That's the reason patient can sleep well. At the same time, nausea can also be decreased. Safe in smaller dosages and use carefully in elderly. Why in elderly careful? Because it triggers tremors. Elderly patients with Parkinson's and other symptoms already they have tremors. It can further aggravate those symptoms. And the other most common drug we use is dexamethasone. You all know about Dexa, the typical corticosteroid. And the Dexa can also be given oral, IV, and sub-Q. This can also be given sub-Q. Okay. And then when are we using this Dexa? When brain pressure, liver swelling, gut wall swelling. Wherever you see pressure, swelling, and swelling, that is called inflammation. Since it is a steroid, it actually reduces the inflammation. In case a patient is suffering from a brain tumor, the huge tumor is causing more intracranial pressure. When you give typical dosage of dexamethasone, it reduces the tumor pressure. In turn, patient reduces the intracranial pressure and then reduces the nausea, vomiting. Yeah. When you're giving this, watch for why it has a tendency of increasing blood sugar levels. So look at blood sugar levels and mood swings because of typical high level of blood sugar levels. And when you're giving this, you should not give this medicine after 4 or 5 p.m. because it will actually disturb your sleep pattern when you give any corticosteroid in the evenings and nights. Typically, it will disturb the sleep. That's the reason when you have to give this medicine, choose it giving before 5 p.m. or 4 p.m. only. And the nursing notes, give in the morning. Yeah, that's what I was trying to mention. Not first choice unless clear reason. So in the order I mentioned actually metoclopramide and then ondansetron and then haloperidol, then you go for dexamethasone. So this is actually in order. Yeah. There are many other medicine, but these are the most common medicine we use. there's no worry about medicine because we both as a team, you and me as a team, we work for medicine and you need to know about most common medicine routes and how to give that. Yeah, coming to the management general principles. What is that? Identify and remove reversible causes. We call it correct the correctable. If you can correct something, for example, this is because of constipation, maybe rather than keep on giving some medicine, why cannot we correct constipation and in turn the nausea vomiting will be corrected? So we can correct the correctables. Maybe because of medicine, maybe opioid also causing nausea vomiting. Then you decrease the dose or stop the medicine, find the alternative medicine. So there is correct the correctable. Or sometimes just now I mentioned because of some organic, dysfunction, some amount of, toxins are more, then maybe you correct that also possible. And sometimes non-pharmacological sorry. Yeah, this way, first thing is to mind is correct the correctable. Any correctable option will correct that. Then address medication side effects, just now we mentioned, and improve non-pharmacological factors and support hydration and nutrition, respect dignity and privacy. Why are we talking about dignity and privacy in this matter? Nausea, vomiting has any relation to dignity and privacy? What is dignity actually? Can anyone mention? Giving a medicine or injection to control nausea is easy actually. If not one injection, two injection or something else, we will try and give. But end of the day, are we controlling patient symptom or are we keeping the patient comfortable as a whole person is matter? Right? For example, imagine about any person you respect in your family or imagine yourself at least. What happens? Me, Dr. Kamblakar, as a dignified person, I have my own set of rules and respect to live. At one point, I have no control on my body. Someone else is doing all my jobs. For example, now I am not in a state where I cannot even reach out to a washroom or sink to vomit. Then I am vomiting everywhere, soiling the clothes, and that kind of a feeling gives me, losing control on myself, right? And then people are watching me, and then that is kind of a sight itself giving me typical, distress. How to control those things? Respect their dignity, right? What to do? Usually, what people they say, someone is vomiting, chalo, go away, don't vomit here. Like that, we show typical expressions in our face, and then we show typical body language, and as if they are, a very antisocial element or someone sinful person, jaisa we treat them. That is very, disrespecting them as a person, right? This is just a symptom. They are the same person. They have their own values, everything intact. Only thing is their body is not supporting them. That's the reason this person is vomiting. And then just because of that, someone is treating them bad, it is again. Yeah. So giving injection and controlling vomiting is one side, and respecting their dignity is the other side. If both should go hand in hand, if you can't respect them and provide you know at least you provide some tub next to their bed or keep a screen where they can have personal space or sit with them and let them know that this is normal, this is very natural for any person in that state, it is not abnormal. Such statements and your body language, your tone, and the way you are caring them is really going to make a big difference, just not giving an injection or medicine, right? And also reassurance to the patient and family. And the most important part I want to mention is to document. This document is going to save you and me together. For example, you didn't document what medicine patient took, how much dose this patient took, what was the symptom, how many times vomited, what was the color, right? Every single thing is really important. I usually ask my nurses in the ward in case they cannot write in English. write in your own language, in your own words, no problem. At least you try to mention the document. What happened to that patient? What did you do? What we gave? If there is no document, at any point of time, document not only save ourselves, provide proper care to this patient also. When you document things properly, when you are handing over this to other, colleague, your other friend, and then they should go through this every single thing. If you don't document something properly, they again have to work on this patient for 1 more hour. We are wasting time, and at the same time, you have energy. You can ask some questions. But what about this poor patient? Everywhere, everybody is coming and asking the same question and again. They'll be irritated, right? So, documentation is very important. You should have every single thing maintained in the document. Once you don't know proper statements to write, write in your own words. Write in your own words. Mention the time. Mention whatever you see in your own words. That is really important. Now, what is the non-pharmacological measures in this case, nausea, vomiting? Explain the cause. Why this is happening? Let them know. Reduce force feeding. For example, family को they only know one thing. उनके ऊपर just they want to show love and affection. Which way? How they will show love and affection? By feeding them. बेचारा उनको already खाना टेस्ट पता नहीं चल रहा है, उनको बहुत उल्टी मतली हो रहा है, ऊपर से आप फीडिंग कर रहे हैं उनको ज़्यादा, तो पेशेंट चिड़चिड़ापन में आ जाएगा, एकदम रेस्टलेस हो जाएगा, हमको को गाली देना शुरू कर देगा उन्होंने, हाँ, he'll be scolding us and then we'll be forcing them. Do not force feed the patient. And dietary advice, non-spicy, this, bland food and small. Imagine a patient is typically nauseating and vomiting, and you're going with this big plate and everything in the plate, the many things in the plate. Do you really feel like eating when you offer such thing to a nauseating patient? No, by looking at that plate itself, the patient will be, feeling vomiting, nauseating. So rather than that, we have to give small amounts, little amount, how much ever the patient can take, that is the best way. And consistency of food, soft and liquid. Avoid fizzy drinks, that they themselves cause typical fumes and smells. And avoid sight and smell of food. Kitchen doors are open, please kept shut for some time. All those things they don't know. Family members, they don't know. They may be thinking something else. They are cooking the best dish for their mother, and then this mother is vomiting in the drawing room by feeling that smell. And then daughter may be thinking that I'm preparing because my mother is vomiting, poor, she couldn't take anything, I'm preparing the best dish for her. You are thinking out of love, but that is not going to justify this poor mother who is, for the cause itself. So you need to think about it. Who knows? We know that. When we know, we need to educate this family member. Not only giving haloperidol or metoclopramide, perinase is not going to help them. You need to holistically help this family. You should know the knowledge. You know the cause. Sit with them and tell them everything possible. They are not with you every time, right? They go home. Then how to take care of this patient at home? Maybe sometimes. Then you guide them. Right. I think that is for nausea and vomiting. I don't know what is the time now. It is already 1 o'clock. I think we'll wind up the session by 1:30. So yeah, for this session, nausea and vomiting, in case you have any questions, please now. I'll take 1 to 2 minutes. Then we go for this, symptom constipation. You can raise your hand or unmute yourself and ask directly. If someone is asking, others, please unmute. Otherwise, I'll ask. How many are there? Only one four. 40. Right. Okay. Shall I ask Renu? Miss Renu? Where is Renu? Renu, can you unmute yourself and acknowledge just that you're there and you're going through this? Right. I totally appreciate someone, Sunita Jakhar. I appreciate her because I see her. She's so much of surroundings and typical resources are disturbing her. Still, she is able to pay attention. Thank you, Ma Sunita Jakhar. Right. Okay then. It's okay. No questions, right? You're unable to see. Are we missing anything because of technical problem? Are we missing any charts and questions? In case we missed the charts, please unmute and let us know. Okay then. Yeah. Now the next symptom we are going to deal is constipation. Yeah. So what about definition of constipation? It is again subjective sometimes, but look at this. Passage of small, hard feces infrequently and with difficulty. Look at those bold words. Hard, infrequently, and difficulty. Okay. For sometimes you may be asking a patient, I never had constipation. I am passing stool every day karke, they will tell. But when you ask them, how are you passing? How much are you passing? What is the consistency of the stool? Then you'll understand, even though you're passing stool every day, that you're constipated. We'll go through that. So individuals vary in the weight and they give to the different components of this definition. That's the reason you please mind about these bold things: hard, infrequent, and with difficulty also. You're passing every day, but difficulty, that is also constipation. You're passing every day, maybe small, hard, constipation, infrequently, constipation. Now, the third most common symptom in palliative care, constipation, and about 50% of palliative care patients, they complain you about constipation every day, and 80% they require laxatives. There is a reason for this, we'll discuss. Yeah. When you go to rounds, as I mentioned, out of 8 patients in my ward, definitely sometimes eight patients, Pura, they will mention about constipation. Because maybe they are on opioids also sometimes. You know about opioid induced constipation by now. Now you see associated symptoms. Flatulence, the typical gas, and bloating, abdominal pain, feeling of incomplete evacuation, and symptoms with complication, anorexia. You know anorexia, right? Not feeling like eating, and days and days you don't feel like eating, and minimal eating, and pain, bowel obstruction, overflow diarrhea. This is one more thing. It itself take one more class actually. You please read about overflow diarrhea. People sometimes they think about it is diarrhea and keep on giving medicine and it will precipitate more constipation. What is overflow diarrhea? If you can see my fingers here, imagine that this is stomach and these fingers, upper and lower bowels, and then there is low motility for these patients, and typically they didn't pass the stool, and the stool is totally accumulated there in the bowel loops for days and days, and it is typically after some days, typical bacterial infiltration, then they started leaking. That is called leaky, and it is leaking through the rectum and typical foul smell, and people may be thinking that that is diarrhea. That you may have to ask this patient, since how many days you are facing this problem. Before that, have you passed stool or not? So we need to assess that patient properly. Otherwise, you may be thinking it's diarrhea, giving more and more medicine, and it'll more constipate. Okay, that can also be a complication. And confusion, delirium, nausea and vomiting, and urine retention. This is one common uh, symptom you see in palliative care setups. When constipation is not dealt properly, because of typical fecal impaction, there is more pressure on the bladder, and then in turn there is no urine output. You keep on inserting catheter. Sometimes maybe there is no need of a catheter. Maybe you just give enema or clear constipation. The patient doesn't require another intervention, which is painful and undignified sometimes for them. A negative sense of well-being when you don't pass stool. Imagine, usually elderly people above 50, 60, You go with them and sit with them. They are looking good. Everything you may be feeling that they are all good, but they didn't pass stool today. Whole world is collapsing for them. They mentioned like that. आज मैंने, I didn't go for stool. Then उनका पूरा दुनिया it is upside down. True, because they got used to that kind of a system. One day they didn't pass, they don't feel well at all, and that is important. That's not that simple symptom. For his well-being, we may have to work on that. Assessment. Again, simple thing is to ask the patient and caregiver. What do we ask? When was the last bowel movement? Sometimes people they have usual habit. For some people, they from so far they know they usually pass stool once in 2 days, maybe once in 3 days. That is their bowel habit. And then you don't inquire that, and then someone mentioned that 3 दिन हो गया motion pass करके करके बताया. So you may be thinking that it's constipation. No, that is normal to them. They have no problem with it. And then you started giving something, you're keeping them into trouble. So you should ask them their pattern also. Okay, daily or alternate days usually they pass. They got habituated to that pattern maybe. And any straining, any bleeding, right, or discomfort. So is the abdomen bloated or painful? Appetite, nausea, vomiting, and are they passing fleetus? So what do we do? Usually we need to observe. What do we need to observe? Abdominal distension, bowel sounds, high pitch sounds or low pitch sounds, or dull sounds, fecal matter around anus, possible impacted or with outflow diarrhea. Check. What to check? Medications. Opioids like morphine and other opioid medication, anticholinergics, they also in turn reduce gut motility. And iron can also, if it is not absorbed properly, maybe 30% of the iron is absorbed, 70% actually thrown into the gut, and then that iron itself going to reduce the gut motility, that can also cause constipation. Fluid intake, how much fluid they are taking. Bedbound or immobile. When a patient is typically not a cancer patient, but a Parkinson's patient or a dementia patient, or typically old age issue, they are bedbound, their muscle tone is lost. They cannot push the stool also. They are constipated. So we need to check all those things. And diet, especially whether they are on fiber diet or what are they taking, we need to check. Digital examination. Okay, the digital examination. So constipation more than 3 days, then fecal leakage, you go for PR, per rectal or stoma maybe. You will have the class and stoma, colostomy and other stoma management. In the stoma, we can also check digital rectal stoma examination. What to check? Are there any hard stools in the rectum or stoma, or tumor or mass, tender or not? Okay. And in case there are other diseases concomitant like hemorrhoids, anal fissures, perineal ulceration, etc. Then, if it is empty and hard or even impacted stool can lie higher in the bowel. Okay. So what do? We need to manually evacuate that, and sphincter tone and rectal sensation. Cancer related, usually intestinal obstruction can cause, and spinal cord compression. When there is a cord compression on the spinal cord, there is a compression, and then there is no signal to the downward area, lower limbs, and then patient will not, pass stool, and there is no movement. Anorexia, hypercalcemia. Because of hypercalcemia, also there is total reabsorption of the water, and gut will be totally dry, and then more hard stool. And fluid loss also can cause in turn constipation. Medication, as we discussed already, all those medicine. Hyoscine means, that hyoscine butyl bromide, the Buscopan, Buscogas usually you call. Tricycle antidepressants like, amitriptyline usually you call Triptomar. This is one saying usually we use. Whoever writes the opioids, if they don't write the laxatives, like, the laxatives are, to use for constipation, to relieve constipation. We don't write, then you are doing a bigger mistake because you're precipitating constipation. You know that opioids cause constipation and you don't give medicine for constipation. You're making a mistake. Then you have to go and do that rectal examination. This popular saying, sarcastic saying. Management. More than laxatives, what do we need to pay attention on? Other symptoms like pain, adequate hydration, balanced diet. If patient is able to take, then only mobility. Patient is totally bedbound, not possible. At least passive movements, passive exercises, at least wheelchair, ambulation. And access to toilet, privacy. Use commode next to the bed. Maybe patient may not be able to go to washroom. Maybe they will not like to use diapers sometimes. That is dignity matter. Talk to the patient. Make sure that there is a commode next to their bed, right? Handrails also. Sometimes they want to, imagine me and now I'm in 40s. I'm totally independent. Now I'll be 80 or 70. My body will be dependent, but my mind will be totally independent. I don't want to use anything. Then proud may no, I want to use something, then I'll fall and I'll have other issues, right? Position. And also address reversible causes. What are the reversible causes? Hydration can be, and medication, opioid issues, all that. Look at this is main thing for nurses. Principles of laxative use. I'm not going to tell you that what is bulk farming laxative and what is stimulant laxative. No, you'll learn the practical principles here. Look at this. In case constipation without colic, colic, the typical abdominal pain, cramps. कॉन्स्टिपेशन है पेशेंट को, लेकिन पेशेंट को कोलिक की पेन नहीं है, दर्द नहीं, देन वी कैन यूज स्टिमुलेंट लैक्सेटिव which is bisacodyl. Usually you know with the brand name called Dulcoflex and Dulcolax. Okay, पेशेंट को कॉन्स्टिपेशन है लेकिन दर्द नहीं है, then you can use stimulant laxative. Why? The name is itself stimulant. Already patient is having typical abdominal colicky pain. Now you are using a stimulant laxative. It will further precipitate pain to this patient. So you need to assess the patient. Only constipation without colic, then that way. And then coming to constipation with colic. Patient को constipation है, colicky pain है, then cramping and hard stool, use stool softener. Hard stool ko, then you use stool softener, which is lactulose. Usually in brands you'll get what is that? Cremofen, Laxicam, something like that. These are very important. Trust me, they might look simple things, but this is patient's whole world. When we don't mind these things, we are aggravating their problems. Then avoid stimulant laxatives if colic pain is present. Okay. Now combination of stool softener and laxatives. When patient is using opioid medicines and opioid induced constipation के लिए we use both. Bulk forming laxatives are generally avoided in palliative care. Why? You tell me any reason. The name itself is telling you bulk forming. Already this poor patient is unable to push whatever the stool in their rectum. ऊपर से आपने दिया बल्क फार्मिंग, ज्यादा पायखाना जमा होने के लिए जो दवा वो दिया आपने, तो ऑलरेडी जो जब जमा हुआ है वो पुश करने के लिए इतना तकलीफ है उनको, ऊपर से और ज्यादा पायखाना जमा होने के लिए दवा दे रहा है, तो देन हाउ ही विल बी एबल टू पुश द स्टूल, more pain will be there. So usually our patients in palliative care are very terminal, low energy, muscle wasting will be there. Such patients के लिए bulk forming laxatives नहीं देना है. Just like Dufelac करके एक you will find that is bulk forming. We usually avoid Dufelac. And I couldn't say laxative doses must be adjusted individually. एक एक पेशेंट को डोज एडजस्ट करना है. फॉर एग्जाम्पल बाइसाकोडिल के लिए यूजुअली वी गिव 2 गोली एट ए टाइम रात को देते हैं. अगर ये पेशेंट को लूज पैखाना आ रहा है, थोड़ा कुछ आ रहा है, आपने 2 गोली दिया है, तो उनको डायरिया हो जाएगा, एकदम ज्यादा लूज स्टूल हो जाएगा, ज्यादा मोटिलिटी हो जाएगा. तो पेशेंट को पूछना जरूरी है कितना वॉल्यूम में आ रहा है पायखाना, कितना आ रहा है भी पूछना जरूरी है. नो नीड टू बी वेरी शेमफुल. दिस इज अवर जॉब. वी नीड टू टॉक टू द पेशेंट एंड फाइंड एवरी सिंगल डिटेल. देन यू हेल्प द पेशेंट विथ मेडिसिन. Medicines are always there, but when to use is very, important thing. Precisely, we need to use. Okay. And the other thing, usually we go for enema, otherwise, suppository. You know about suppositories, right? When some patients, they cannot take, orally. For example, all these medication can be given orally only. So patient is unable to take orally and constipated. What do you do then? We go for either enema or suppository. Look at the suppository. How to give suppository step by step. Usually in my wards also, when I advise suppository to a patient, still the nurse complains that sir मैंने suppository सुबह दिया शाम को दिया और 2 दिन से दे रहा हूँ फिर भी पायखाना नहीं आ रहा enema दे दूँ क्या? You can give enema, no problem, but enema is a procedure. Can you accept enema simply? Dignity matter, right? When it is necessary, definitely we'll go for it. But before that, there are many other simple techniques, right? तो देन व्हाट टू डू मैंने एक दिन देखा इन लोग सपोजिटरी दे रहा है सपोजिटरी कहाँ रखना है यहाँ ऐसे रेक्टम में रखना पड़ता है सपोजिटरी को ऐसे एक जली जैसा रहेगा बाहर निकालते हैं जली को निकाल के सपोजिटरी रखना पड़ेगा नो यू मस्ट हैव नोन अबाउट दिस टेक्निक बट ये क्या कर रहे सपोजिटरी लेके आ रहे रेक्टम में रख रहा है लेकिन कहाँ जा रहा है वो सपोजिटरी देखिए चेक द पिक्चर वो स्टूल में फंस जा रहा है योर सपोजिटरी ऑलरेडी स्टक इन द स्टूल सपोजिटरी कहाँ रखना है वॉल को रखना है रेक्टल वॉल में रखने से वो मूवमेंट्स आएगा वहां इफ यू डोंट कीप देयर यू आर कीपिंग एवरी डे यू आर डूइंग योर बेस्ट जॉब बट इट इज नॉट जस्टिफाइड एंड ऑफ द डे सो मेक श्योर दैट इज द रीजन यू शुड गो फॉर पर रेक्टल एग्जामिनेशन डिजिटल एग्जामिनेशन कहाँ कितना स्टूल है हार्ड है निकाल दो देन यू गिव suppository when hard stool को नहीं निकाल दिया you want to just simplify your job you keep a suppository or someone else you're monitoring kept the suppository hard stool there अंदर ये मूवमेंट की वजह से हार्ट स्टूल बाहर आ रहा है कैसे आता है एकदम एनल केनाल को रप्चर करके आता है बाहर देन आर वी एडिंग rather than controlling the symptom adding more problems so digital rectal examination is very important before going for any enema or suppository okay एंड इवन गिविंग स्टूल सॉफ्टनर्स पायखाना को सॉफ्ट करने वाली दवा देते हैं ना तब भी हम पेशेंट को डिजिटल रेक्टल एग्जामिनेशन करना है या लुक एट दिस इज लाइक स्टेप बाय स्टेप प्रोसीजर्स ask the patient to lie on left lateral side and wash your hands and wear gloves remove the wrapper from the suppository open karke and apply water based lubricant sometimes lignocaine jelly also and insert the suppository 1 inch almost 2 to 3 centimeters into the rectum to this pars sphincter and patient should retain at least 15 to 30 minutes and then this is the way you can self-explanatory you can go through those points okay yeah we'll share the ppts also later now how to give phosphate enema there are many enemas but usually we go with this how to give this enema step by step can you please go through that patient should lie on same left lateral position wash hands wear gloves check enema bottle gently then remove the cap of that lubricant nozzle and then separate the buttocks gently, insert the knob nozzle, and then squeeze the bottle, totally empty the contents. Ask the patient to retain it for 5 to 10 minutes, as long as they can tolerate it. Remove it and discard, clean. Right? That way. Did the patient pass the end of the this is very important. हमारा जो अब जब तो खत्म हो गया हमने एनिमा दे दिया खत्म हो गया देन फिर जाके पेशेंट से पूछा हमने पायखाना गया कि नहीं दैट इज रियली मैटर and sometimes trust me patient they don't know whether they are passing stool because they have no sensation we need to check okay now cautions for both for enema and suppository do not give if rectal surgery is done or active bleeding is there or known or suspected bowel obstruction perforation जो भी है तभी नहीं देना है right कैकेटिक पेशेंट कैकेक्सिक पेशेंट पूरा पतला हो गया एट द टाइम फ्राइल पेशेंट को भी टफ हो जाएगा पायखाना पास करने में एंड देन ऑलवेज मॉनिटर फॉर डिस्ट्रेस पेन एंड इनकॉन्टिनेंस आफ्टर प्रोसीजर nurses role in decision making look at that important to document time given type and response, and any discomfort or refusal. All these things you need to document. Anything to be documented. I think that was a little quick, but hope you understood. We have some time now. In case you have any questions, practical related, anything, you can unmute yourself and ask. Please give us suggestions also in case we, the teachers or lecturers, may be going one way. You may have to guide us also. Which way would be better? I came to know that most of the people, they're sometimes comfortable with Hindi also. Uh, at any point you wanted us to speak in Hindi, let us try. हमको भी उतना नहीं ज़्यादा आता है. Let us try. At any typical slide or something you totally didn't understand, जो आपको पूरा समझ में नहीं आया, तो in case a speaker is able to speak, we'll try our best.
If anyone having any questions, please ask. I think everyone understood.
Fine. Okay then.
The class was very nice, sir. Actually,
Where is the question? There's a
we were able
question.
to learn about nausea, constipation.
Yeah. Sister, there is a question, I think.
Please,
मेरा
please.
question है, बहुत बार ऐसे पेशेंट्स आते हैं जो लैक्टोलोज ही मांगते हैं हमेशा, और कॉन्स्टिपेशन ठीक होने के बाद भी. ओके, सो हु इज दैट? पिंकी. ओके, ट्रू. व्हाई दे आर आस्किंग? बहुत पेशेंट को एक बार कॉन्स्टिपेशन रिलीव हो गया है, देन दे फेल्ट सो मच रिलीव्ड, उनका पूरा बर्डन खत्म हो गया, राइट? एंड देन दे उन्होंने बार बार आपसे पूछ रहे सेम दवा दो करके. दिस इज व्हाट द क्वेश्चन, राइट? व्हाट टू डू विद दैट? दैट इज द क्वेश्चन. Maybe. Okay. So then you need to find out why are they asking? Why are they constipated constantly? Is there any, उनको कुछ underlying problem है पेशेंट को? पेशेंट को अंडरलाइंग प्रॉब्लम भी हो सकता है. बार बार क्यों पूछ रहा है उन्होंने? बार बार इसीलिए पूछ रहा है पेशेंट को असर पड़ रहा है, पेशेंट को
हेलो
दवा से आराम.
हेलो हेलो सर.
या
हाँ सर, जो पेशेंट है वो लैक्टोलोज का मतलब एक तरह से आदी हो चुका है, मुझे लगता है ऐसा, क्योंकि बहुत बार ऐसे पेशेंट आते हैं ना, जैसे आपने बताया कि एक बार रिलीव हो गया होगा, उनको रिलीव हुआ है तो वो उस चीज को मतलब बार बार मांगते हैं.
वही.
लेकिन क्या एक्सेस में हम लैक्टोलोज अगर जैसे ले ले तो कुछ और भी इसका कॉम्प्लिकेशंस हो सकते हैं?
डेफिनेटली. एनी जो भी मेडिसिन जो भी है ना, मेडिसिन कब देना है, कब विथहोल्ड करना है, एक प्रिंसिपल रहता है. अगर ये जो पेशेंट बार बार लैक्टोलोज पूछ रही, मतलब पेशेंट का कंडीशन क्या है? अगर पेशेंट को टर्मिनल प्रॉब्लम है, इनक्यूरेबल डिसीज है, तो पेशेंट को प्रॉब्लम जब तक पेशेंट रहते है तब तक रहेगा, देन यू मे हैव टू यूज. बट पेशेंट को अक्यूट प्रॉब्लम है, मतलब पेशेंट को कैंसर नहीं है और एनी लाइफ थ्रेटनिंग डिसीज नहीं है, और जो भी ऐसे क्रॉनिक प्रॉब्लम्स भी नहीं है, फिर भी पूछ रहा है, मतलब वो पेशेंट को कुछ करेक्शन कर सकते हैं हम. पेशेंट को काउंसलिंग करना पड़ेगा, क्यों पूछ रहा है, क्यों कॉन्स्टिपेशन हो रहा है, उस चीज के ऊपर ध्यान देना पड़ेगा हम. कॉन्स्टिपेशन क्यों हो रहा है, उन्होंने क्या खा रहा है पूछना पड़ेगा, फाइबर ले रही कि नहीं पूछना पड़ेगा. हाँ,
हाँ
आदत
सर,
पड़
हाँ सर.
जाएगा पेशेंट.
हाँ सर, मोस्टली हमारे पास जो पेशेंट आते हैं डायबिटीज मिलिटिस के आते हैं, टाइप 2 और हाइपरटेंशन के आते हैं, तो जो ये लैक्टोलिस की डिमांड करते हैं ना, उसमें से डायबिटीज वाले ज्यादा होते हैं. और उनका ये कंप्लेन होता है कि हम जब डायबिटीज की मेडिसिन खाते हैं तो कॉन्स्टिपेशन वाली प्रॉब्लम वो फेस करते हैं,
यस
इसलिए उनको वो चाहिए ही चाहिए.
यस. तो मेटफॉर्मिन वगैरह जो दवा देते हैं ना डायबिटीज में,
हाँ जी सर।
तो ये दवा से भी उनको कॉन्स्टिपेशन प्रेसिपिटेट होता है, लेकिन ये जो कॉन्स्टिपेशन है ना, उनको दवा से अच्छा अदर नॉन फार्माकोलॉजिकल मेंटेनेंस से कम होता है। किसे? पेशेंट को हमने मोटिवेट करना है, उनको फाइबर खाना लेना है, रात को गर्म पानी पीना है, खाने के बाद वॉकिंग करना है मोटिलिटी होने के लिए। ये सब ना थोड़ा अटेंशन से ऑर्गेनाइज्ड काम करना है, तो इसके लिए थोड़ा पेशेंस रहेगा। बाकी लोग क्या करते हैं, उतना पेशेंस नहीं रहेगा, एक लैक्टोलोज का 2 ढक्कन ले लेता हूँ साफ हो जाएगा करके इजी वे ढूंढते हैं। तो
ओके
इसीलिए
सर।
उनको हमने मोटिवेट करना है लाइफ क्वालिटी के लिए। दवा
हम्म,
के ऊपर डिपेंड होने से आने वाले दिनों में ऐसे अब खतरा में रह सक होने की
हाँ
चांसेस है, तो
हाँ,
ढूंढ
बेसिकली
ले।
लाइफस्टाइल मॉडिफिकेशन के लिए कहना होगा, है
ट्रू
ना?
ट्रू ट्रू। यस।
ओके ओके, थैंक यू सर।
Yes, yeah. Okay, then we'll wind up the session and we'll meet you in another session in bowel obstruction. Okay, right.
Thank you, sir. Thank you for this valuable session. Of course, we faced a lot of technical issues. Sorry for that. And I have personally forwarded some session links to someone. So after this session, please connect with me because their attendance is not showing on the website, on the platform. So for the certification, it's very necessary. So please connect with me after the session. So you can leave now.